I am talking on intoing and outtoing in children, an extremely common presentation in the pediatric orthopedic OPD. So let's first understand what is intoing and outtoing. So when we walk, our body makes a certain line of progression, and the long axis of our feet, it makes a certain angle with respect to the line of progression of the body. And this angle is basically known as the foot progression angle. Now, usually we walk with a slightly external foot progression angle of about 5 to 10 degrees. However, there is a wide normal range ranging from about 5 degrees internal to 20 degrees external. So anything that falls outside this range would be called intoing. So if intoing or outtoing. So if the internal foot progression angle is more than 5 degree, that would be intoing. If the external foot progression angle is more than 20 degree, that would be outtoing. Now, how do you approach a child with intoing or outtoing? So basically, there are two main parts to the evaluation. Firstly, you have to rule out any underlying neuromuscular pathology. And having done that, once you are sure that the child is a neurotypical child, does not have any other problem, you have to evaluate where the intoing or outtoing is arising from. Is it arising from the foot? Is it from the tibia? Or is it from the femur? So in neuromuscular pathology, two common, neuromuscular pathologies which can lead to, torsional problems are cerebral palsy, where intoing is commonly seen in the younger child with excessive femoral anteversion, and outtoing is seen in the older child, which is due to tibial external torsion. Similarly, in spinal dysraphism, we very commonly see outtoing, which is due to combination of torsional anomalies of the femur as well as tibia. It is important to correct the foot progression angle in children with neuromuscular pathology, because otherwise they lead to what is known as lever arm disorders and energy inefficient gait. So in these cases, it is important to correct the intoing or outtoing, but this topic is outside the purview of today's talk. What I'm going to mainly focus on today is the intoing, outtoing that we see in a neurotypical child. So having ruled out that there is any underlying neuromuscular pathology, you should then proceed to find out where your intoing, outtoing is arising from. So it can arise, as I said, from the foot or the tibia or the femur, and you have to evaluate each of these segments. In the foot, intoing can arise because of, metatarsus adductus, that is a bean-shaped foot. And this can be easily assessed on inspection by looking at the foot from the plantar aspect. So metatarsus adductus would lead to intoing. Similarly, pes planovalgus or flexible flat foot will lead to outtoing, and this is best assessed by inspecting the foot in a weight-bearing position. So you will see loss of medial longitudinal arch of the foot. You will see excessive eversion at the level of the subtalar joint. Having evaluated the foot, then you go up, evaluate the tibia. So how will you identify tibial torsion? So first clue that you will get is look at the axis of the foot with respect to the direction of the patella. So if the axis of the foot is inwardly or outwardly deviated with respect to the position of the patella, it indicates that might be the child would be having a tibial torsion. Next, you look at the thigh foot angle. This is done by making the child lie in the prone position and flexing the knee, and you look at the axis of the long axis of the foot with respect to the long axis of the thigh, and that will give you an idea whether the child is having a tibial torsion. And finally, you can look at the orientation of the intermalleolar axis with respect to the intercondylar axis. So these three simple clinical tests will give you whether the child is having any tibial torsional deformity. Then you proceed further higher up to evaluation of femoral version. So how do you assess the femoral version? Number one, look at the position of the patella. If the patella is pointing either inward or outward, you know that the intoing or outtoing is arising from the femur. If the child prefers to sit in a W position, then it indicates that the child is probably having a femoral anteversion, excessive femoral anteversion, and so he or she is more comfortable to sit in the W position. Then you look at the hip rotations. So if the hip rotations are asymmetrical, which means that the internal rotation is excessive, but the external rotation is limited, then it indicates that the child is having excessive femoral anteversion, and vice versa. If the internal rotation is restricted and external rotation is 70-80 degree, then probably the child is having a femoral retroversion. And finally, you can do what is known as the trochanter prominence angle test, that is also known as the Craig test. Here you palpate the greater trochanter and rotate the hip till the greater trochanter is felt to be maximally prominent. The angle of hip rotation at which the GT is maximally prominent is the angle of femoral version. Now this is about the clinical examination. On radiological examination on imaging, obviously X-rays won't give you any idea about the torsional abnormality. Here, if you have to quantify the amount of torsion of the femur and the tibia, you would have to do a CT scan or an MRI and ask for a torsional profile. So here, transverse cuts are taken at the level of the proximal femur, distal femur, and proximal tibia, distal tibia. And the orientation of the axis of the proximal and distal ends of the bone will give you an idea whether the child is having any femoral or tibial torsional abnormality. Having said that, now what is the clinician now has to be aware as to what is the natural history of femoral or tibial torsion. So the angle of femoral and tibial torsion does not stay constant throughout childhood. As can be seen in this chart, the femoral anteversion is maximal at birth, almost about 40 degrees. It progressively decreases as the child starts walking, and by the age of 10 years, it decreases to about 10 degrees of anteversion. On the other hand, the tibial torsion angle more or less remains same throughout the growing years. So the clinician has to be aware of this in order to predict the further natural history of the intoing or outtoing. Also, if you look at the rotational profile of the lower limb at age of 8 years, what you can see is by the age of 8 years, most of the children, about 90% of them, have achieved normal torsional profile of the femur as well as tibia. About 10% of the children at the age of 8 years do still have intoing, and in half of these cases, it may be due to tibial intorsion. In half of these cases, it may be due to femoral anteversion. But there is a small percentage, about 1%, who will have a combination of high femoral anteversion with low tibial internal torsion. Now this condition is particularly important. It is what is known as the torsional malalignment syndrome, and this is important because this can lead to anterior knee pain, and in uncorrected cases it is known to cause patellofemoral problems later on in adulthood. Therefore, this torsional malalignment syndrome, it should be corrected. Finally, if we know the natural history of femoral and tibial torsion, we can predict that this is going to get better with age. However, surgical correction is needed in extremely rare cases. In neuromuscular cases, yes, it is needed, but in the neurotypical child, surgical correction is almost never needed. It is reserved for those cases where significant torsional malalignment persists beyond adolescence and it is causing functional limitations. Then in torsional malalignment syndrome, yes, it should be corrected because as I mentioned, it will lead to patellofemoral problems in the future. If you want to correct a femoral torsional abnormality, a proximal osteotomy is preferred, whereas in a tibia, the distal osteotomy, derotation osteotomy should be preferred. The reason for this is you don't want to do the osteotomies closer to the knee and interfere with the extensor mechanism of the knee joint. Fixation can be either with a plate, nail, or external fixator depending upon the preference of the surgeon. So these are an example. This is a femoral proximal femoral derotation osteotomy fixed with nail, and to the right is a tibia derotation osteotomy that has been fixed with a plate. So to conclude, intoing and outtoing can arise from the foot, tibia, and femur. You have to evaluate from which segment of the lower limb it is arising from. Majority are physiological and are going to resolve with age. The clinician should be aware of the natural history. And surgery is reserved for cases where significant functional limitations persist beyond skeletal maturity. Thank you.